Anesthesia is a procedure used to eliminate pain and sensation ahead of surgery. That's our focus today on Sound Health. I'm Olasumbo. Welcome to the show. Welcome back. It's still Sound Health on Lagos Television. And today we are looking at anesthesia in the field of medicine. And I have with me a consultant anesthetist, Dr. Olajide Ayeni. Welcome to the program.
Thank you very much, and thanks for having me.
Okay, to start with, what is the role of anesthesia in achieving successful surgery?
Oh, anesthesia, so to say, the role can never be overemphasized when it comes to success in surgery. And in the time past, I've always stressed this. For surgery to be very successful, you need very good anesthesia. And at the same time, for anesthesia to be successful, you need a competent specialist. That's an anesthetist. If I might categorize, anesthesia plays the roles of making sure the patient does not have any pain during surgery. Apart from that, the supportive role of ensuring that critically ill patients get well. That's in our ICU, in our high dependency units. And even at that, we also offer a lot of other services when you talk about chronic pain management and all the rest of it. So let me just leave it at that.
Okay. What is the difference between epidural and anesthesia? Are there other methods of this procedure?
Anesthesia is a broad term, but underneath the term anesthesia, you have general anesthesia. This is where a patient goes completely to sleep. Is not aware of the environment that is artificially created by the anesthetist. Then the second group is the regional anesthesia. And the regional anesthesia is where you have to actually deaden some certain area with your anesthetic agents. And epidural happens to fall under that class of regional anesthesia. Other types under regional anesthesia is the subarachnoid block, and then you have local infiltration, where you just inject maybe a little finger or inject that part of the body, and then to ensure that there's no pain while we're carrying out some surgical procedure.
When does anesthesia becomes an option? Is it a must for every patient?
For every patient that is going to have surgery, anesthesia is always an option. And just like patients are being consented for surgery, the same way patients are going to be consented for anesthesia. So in a standard practice, there is a consent form for actually people that are 18 years and above, which are considered eligible to actually consent for themselves. For people 18 and lower, the parents or the surrogates can actually take the consent for them. And the consent, in terms of standard practice, the procedure that the patient is going to have will be explained. The procedure of anesthesia will be explained. The type of anesthesia the patient is going to have will be explained as well. The risk and the benefits, you understand, that follows the anesthetic procedure will be explained to the best knowledge of the patient. And then at the end of it, the specialist anesthetist will sign with the time and the date. The patient as well will put pen to paper that, yes, I agree for you to carry on the anesthetic procedure. So it's always an option. And the options are, if a patient is going to have, for example, a cesarean section, which is common in our environment, well, surgeries come in form of emergency or elective. When we say elective, the patient and the surgeon, they've agreed that on so day, we're going to operate you. We're going to deliver you by cesarean section. Yes, the anesthetist is also notified that a particular patient will be coming for so procedure on a set date. So the anesthetist will have seen the patient like a day before. And the essence of the visit is to actually tell the patient about the anesthesia. And so there's exactly, and to prepare the patient. And the option, is always there. It can neither be general anesthesia or regional anesthesia to the advantage of the patients. And these options actually depends on the physical status of that patient at that time. Okay. Yes. So for a proper anesthesia to be delivered, the anesthetist is notified that a patient A is coming for cesarean or any other form of surgery on a set date. And the anesthetist will have planned the time to pay the patient a visit. The extent of the visit is to, is group into 4. The first one is to make sure that the patient is not anxious. For example, the patient is being counseled for surgery. And majority of times, we see them, they are so anxious, they are worried. Even a day prior to the surgery, they could hardly sleep. So it's the job of the anesthetist to allay the anxiety. That is 1. 2, if there is any underlying medical problem that could present a challenge during the surgery, the anesthetist will actually examine the patient to see whether the patient is fit or not for the surgery and ensure that proper medication that will actually make the patient fit for the surgery is administered a day before. That is secondly, we call it pre-medication. Thirdly, is to actually assign this patient to a particular category in anesthetic platform.
Talking about options, what category of patients needs anesthesia? Are there any health conditions you need to take into consideration before administering anesthesia?
We have about 5 categories. Category 1 is just a normal patient. We call it ASA. ASA means American Society of Anesthesiologists 1, which means patient is normal when it is 1. ASA 2, American Society of Anesthesiologists 2, means that patient had some maybe undercurrent mild illness, like maybe blood pressure, though it's controlled. Maybe the patient is asthmatic, though it's normal. Maybe the patient has diabetes that is controlled. This is ASA 2 patient. ASA 3 means American Society of Anesthesiologists 3, which means patients that have some life-threatening condition, but it's not incapacitating. You understand? ASA 4 is a patient that has a life-threatening condition and is incapacitating. For example, a patient with possibly maybe renal failure, patient that had some deranged blood issues like electrolytes, we call them. So such a patient, is a very, very poor patient, ASA 4. Then ASA 5 patients are patients that are moribund. When we say moribund in medical terms, it means with or without surgery, that patient might not survive 24 hours. You understand? And ASA 6, which is for advanced learning, means a patient that is brain dead. So when we review this case, whether it's elective or emergency, we assign them under each category. And the essence of this is to actually help you to predetermine your anesthetic care that you are going to deliver to that patient that's in the theater. So when it's an emergency, we put an E at the back. We say ASA 1E or 2E. So with this visit, I've mentioned 3 things. 1, to remove anxiety of the patient. 2, to actually put this patient in a physical status. 3, to actually pre-medicate the patient.
Like health conditions.
Yes, like somebody that is asthmatic now, that has an asthmatic attack that is recent. By the time the anesthetic is reviewing, and you are likely to pick 1 or 2 signs, maybe with the stethoscope, you say, oh, this patient might need some, maybe Ventolin inhaler, or maybe this patient might need some. So that is like a pre-medication just to prepare the patient for the surgery. And if perhaps the patient will not benefit from the surgery, you reschedule. There's what we call rescheduling in anesthesia. That from what I've seen, this patient, because it's an elective, patient is not likely to die within 24 hours or even a week. If we don't do the procedure, then we can reschedule this procedure for next week, because this patient, as I'm seeing now, is not fit. So pre-medication anxiety, then to assign the patient whether it's fit or not. And then lastly, for you to have a rapport with your patient. So you don't just see patients in the theater and you jump on the patient and you want to start giving anesthesia, but you have established a relationship with your patient, which further buttress the issue of anxiety. It nullifies your anxiety. And if we're talking about minor patients, like we're talking about pediatrics patients, maybe a toddler, you've bonded with your patient already. And that bonding, when you're seeing the patient in the theater the next day, is a bit calmer when they see you. I saw this face yesterday. Hey, he was gisting with me, he was talking to mommy, and they feel much more relaxed in your presence. So that's the essence of anesthesia.
Have you ever had cases where patients declined the procedure?
Yes, we've had cases where patients declined the procedure.
What was the way out?
Well, the way out was simple. We have to reassure the patient, because anxiety in any environment, if not properly managed, can lead to misinformation. So the first example of such that I witnessed was a misinformed patient, peer group pressure, patient that was being prepared for fibroid surgery. A friend has heard of a sad experience somewhere else, that somebody went for fibroid surgery, the person didn't come out, and as such, that agitation was already there. And to now crown it all, the anesthesia review, was too close to the surgery. So you're seeing a patient now, and you are preparing to go in the next 2 hours. You can be assured that she won't be much more relaxed. So at a point in time, with all the information she has had in the past, so she almost declined the surgery. But as a specialist, I have to actually investigate and see the roots of why she was behaving as such. She came out frankly and said, look, that at this point in time, she had already made up her mind before, but from thinking over past experiences from friends, that she suddenly felt a cold feet, developed a cold feet. So I had to reassure her. And reassuring means explaining in detail what it entails, what the procedure entails, that if the need arises that we transfuse her, I will transfuse her, but I will not transfuse her. That is, transfusion means giving her blood. I will not give her that unduly if she doesn't need it. I must have assessed and see that there's a need for blood transfusion. So all those affairs, one by one, I didn't know that I was actually bringing it out and dealing with it. By the time we chatted for just like an hour, she was very, very calm, and she offered herself for examination, and then lo and behold, the surgery was successful.
Okay. The procedure prevents pain. Are there any side effects as a result of anesthesia?
There is no procedure that you embark upon that doesn't have its own side effects, even drugs. But one thing we need to differentiate is side effects from complications. Side effects are effects that you obviously will get from a particular procedure. So the onus is on you as a specialist to tell them that when I'm doing this procedure, you feel like this, you feel like that. Like the general anesthesia, one of the side effects is when you are waking up, you're bound to feel a bit drowsy and a little headache. So you sometimes counsel your patient ahead that when you wake up, you experience this, you experience that. So that's side effect. But complication, they're actually something you don't want. Yes, complication might occur leading to grievous outcome. You understand? And you tell them about the complications, but it doesn't mean that the complication will happen. So you give them we call it the incidents. Like you say, okay, maybe this will happen 1 in 300,000. And you can tell me, I can tell you that is, to the barest minimum. It's like you leaving your house daily to cross the express, to cross the main road, but we don't get knocked down by vehicle. That is how the complications should be. But for side effect, it's something that you know that it will definitely occur. So you discuss this when you are consenting your patient to actually let them know that this can happen, but it hardly happens. And of course, in the hands of a competent specialist, you can hardly see that happening. And when it even happens, it's manageable. That is the essence of education you can give to your patient, that this can happen, it hardly happens, but even when it happens, these are the ways to go about it. And that's why consent should be standard.
3D visualization and augmented reality for surgery.
Surgeons have relied on microscope oculars or other camera systems to operate. However, surgeons also typically depend on their own eyes and interpretations to execute the most precise tasks. Two of the most intricate surgical practices, neurosurgery and retinal microsurgery, have been experimenting with new technology in the past year. These stereoscopic systems not only keep a surgeon's head up, but it immerses the surgeon into a high-resolution 3D visual representation of their subject. Experts and surgeons that have piloted the new systems believe the added comfort and visual information will allow surgeries to operate more efficiently and effectively. A growing number of hospitals will be adopting these new systems in 2017, pushing the boundaries of surgical reality as we know it.
This is where we say thank you on today's edition. Hope you've learned a few things. For comments and inquiries, please send SMS on 0818-815-3695 or follow us on social media at LTV Social, #Soundhealth. A sound health is a sound mind. Make healthy living your choice.